We'll get started here. So thank you everyone for being here for this webinar. So what we'll do is basically what these discussions are designed for is to share resources amongst physiotherapists in Canada and also within the UK today. So I'd like to welcome everyone from Canada and some colleagues and friends that are in the UK right now. And I know we've had a few physiotherapists joining from other countries like in Norway and potentially Nepal as well tonight. So thanks everyone for being here. We have two incredible guests here today. So Pete and Bronwyn, and I'll introduce them in a few moments. But if you're new here, basically what the structure is, we go through a situation report that Mike runs us through. And then we'll have Pete and Bronwyn talk about some of the initiatives that they're involved with and some of the principles behind preparedness, planning, and response in terms of rehabilitation and physiotherapy. And then we'll open it up for discussion at the end. So Mike, I'll pass over to you for the situation report.
Yeah, thank you, Phil. So yeah, this has been our usual, is just to kind of go back to the macro level, look around the world on some of these numbers. And I think maybe a few of you might be new to the format that Phil and I have been doing into the CPA webinars. So pardon me, I'll be mentioning numbers, and they're large, but I don't want to camouflage behind each one of those numbers as a person and a family, and some of the tragedies that are occurring around the world are quite important. So please don't think about these numbers as being sort of overly blunt, but it is good to get a perspective of what's going on. So just right beside me here, I have the most recent situation report from the WHO, and so we'll always sort of try to send you to very reliable sources. WHO is certainly one of them. In Canada, the Public Health Agency is another. Weaknesses of all these data sets, but these are, in our opinion, the most reliable. So if we looked at the situation report as of yesterday, this is moving incredibly fast. Our global numbers of confirmed cases are close to 700,000 at this point. Within the last 24 hours, an additional 58,000 people have been confirmed. Tragically, 33,106 deaths globally, 3,215 globally in the last 24 hours. And so, these are pretty large numbers. We know that the numbers kind of changed. The wave has moved a little bit from west in terms of new cases and what's called case fatality rates. Europe is right in the middle of are close to the peak, and so our two guests today are going to be very informative in terms of some of the thoughts from Europe. I'll mention a few points now about Canada specifically, but again, you can look at all countries through the WHO situation reports. We in Canada at the moment, and this is as of today at 12:35 p.m. Here in Canada, 8,476 confirmed cases of COVID-19, with a number of 95 deaths from COVID-19. Some of the provinces, this is not equally distributed across all of the different provinces, obviously, the jurisdictions. Quebec is running the highest numbers at the moment. They're not the most populous province, but they have the highest numbers, 4,162 with 31 deaths. Couple interesting sort of epidemiological data points, I think at this point that we're looking at. New figures are demonstrating about a 4.9% mortality rate. And this is among those who tested positive. There's clearly a discussion that's happening internationally around what does that really mean. And everyone who's an epidemiologist or scientist, and all of us clinicians out there, you have to be careful with some of these raw data points, and you have to certainly be careful of how they're interpreted. So 4.9% mortality rate is a point estimate, gives us some information. Might not be correct given the fact that we're just not sure what the denominator is. I'll sort of recount a couple points that are interesting as well. If you go to, by the way, the Public Health Agency of Canada, you'll get some interesting information. One bit of information that is reporting some positivity here is that over the last 10 days, the number of patients who've recovered from COVID-19 has tripled. Now, I say tripled, given it was a very low number to begin with, but we are seeing a very nice trend that is going to likely follow the surge trend over time, or at least we hope so. So in Canada, certainly North America is not close to being the top of this surge, but we are seeing some positive news as it relates to some of the recovery rates. So people have actually recovered from COVID-19. Sub-analysis would be interesting at this point to try to understand what were the factors that led to a recovery. Was it care in hospital? Was it some other factors? Was it a combination of factors? There have been, I'd like to raise a little bit of a flag here, across Canada, and maybe for Pete and Bronwyn here, about 90% of the Canadian population lives within, let's say, 150 kilometers from the US border. So the vast majority actually live very, very low in terms of the geography, but that doesn't mean that they're not Canadians spread in the far north. And so in these sort of rural, more isolated areas, and in many cases, they also include large populations of First Nations people, here in Canada. And so I think it's important to start thinking of how different communities are faring out. What kind of access are they having? And so there's plenty of social cultural discussions that probably need to be happening. The numbers that I'm giving here are just literally raw numbers across Canada that include everyone. I'll give you one last little, I think, point that was made, and I'm kind of making this up. I'm pretty sure it was in Newfoundland. I'm not 100% sure, but there was a measure of how long it took to double your rates of reported infections. So the standard number that was being used in Canada for most provinces was that it took 2 days to double your number. So every 2 days you saw a doubling effect. And I'll correct it with CPA. I'll get it posted. I'm pretty sure it's in Newfoundland. But they are witnessing a longer delay in order to get to that doubling effect. And so, in other words, it's taking a longer time to double the numbers. This is still a bad situation, so don't get me wrong, but it seems as though that there is some early indication that physical distancing is having an effect in terms of that community spread, which is representing at least half and growing numbers of reported new cases. So I'll stop there, Phil, and I'll pass it back to you. As we do these situation reports, and I encourage all the people who are on the call right now to think about just going every once in a while, because that's where you're going to get the most up-to-date information. So I'll stop there. What's important for us in terms of physical therapists and healthcare providers is a couple of things. One, we are not just a profession that addresses non-communicable diseases. We are a profession that participates fully in the healthcare continuum. Full stop is one of the taglines I'm trying to use here, because this pandemic, this ID outbreak, will demonstrate the real need for all of us to be hands on deck. And I think we're going to get some really interesting stories from our two wonderful guests today. Phil, over to you.
Yeah, thanks, Mike. And absolutely, just to echo what Mike was saying, when we first started these sessions, we were trying to even put some of the situation reports together in the morning or even an hour before we were actually going live. And then by the time that we actually shared that information, it wasn't even relevant anymore. So the numbers and everything is changing so quickly. So really make sure that you're checking it out on reliable websites around the world and in Canada. So I'm really excited for our two speakers today. I've worked with Pete quite a bit in different contexts. I first met him in Nepal, of all places, and then we've kind of connected over the years. So I'm really excited that he's agreed to do this, and he brought Bronwyn on to also join and share her experiences and her expertise. So Pete Skelton is an emergency rehabilitation specialist with Humanity and Inclusion. He's rehabilitation lead for the UK's emergency medical team and a trained WHO emergency medical team coordinator. Since 2008, he has had clinical leadership and coordination roles and responses to a wide range of disasters, including earthquakes and cyclones, as well as mass displacements outbreaks, and conflicts. So welcome, Pete. Thank you for being here. It's a pleasure to connect with you again.
Yeah, same pleasure here. Thank you for the invitation. Thank you to all of you guys for attending as well. So what I'm going to talk about today really is the kind of global humanitarian perspective of this. So I should caveat this at the beginning that I'm not involved in the UK level response, so I'm not going to talk about that too much, but I'm going to talk about the global situation and to draw lessons from past humanitarian responses that I think have relevance really to the current situation that we're all facing. And then I'm going to hand over to Bronwyn, who is currently or about to begin work with us via the UK Emergency Medical Team. And seconded into WHO, and we'll be taking a lead on some of the global guidance which will be coming out. So it's going to be really exciting to hear from Bronwyn in terms of what's planned from that side of things. What I'm going to do now is share my screen. So hold with me for a second while I do that. Now you can all see my emails. Let me bring up the presentation. There we go. So yeah, I have a split role. So I work for Humanity and Inclusion, also known in Francophone countries as Handicap International. And as Phil said, I'm the rehab lead for the UK Emergency Medical Team. Now, what that is essentially it's the UK government's capability to respond overseas to global health emergencies, everything from earthquakes, cyclones, right through to outbreaks of various different kinds. And the picture that you can see here is the full field hospital in one of its older iterations. So it's a big platform, 2 operating tables, up to 40 beds with dedicated rehabilitation staff that work within it, and 2 rehabilitation teams as well that can deploy autonomously from that. One to provide multidisciplinary rehab and the other to provide spinal cord injury care. So that's the kind of capability that we have through the EMT. But I also work with Humanity and Inclusion. For those of you that don't know the organization, I would encourage you just to give us a quick Google. So we're a global organization. One of our key areas of work is within rehabilitation, and that can be anything from, as you can see here, sort of acute in-hospital rehabilitation, community-based rehabilitation, center-based rehabilitation, and sort of leadership and coordination in emergencies as well. And in a whole host of contexts, so in a development context, but also in my area in humanitarian context, so in conflict, in situations of displacement, and in response to disasters, earthquakes, cyclones, and the like. I should apologize, this is not going to be a pretty presentation from here on in, because I just haven't had the time to sort of beautify it and make it look nice, so bear with me if there's a lot of text. This slide, though, does highlight that we've very recently, with the UK Emergency Medical Team, as Mike was alluding to, also been involved as rehab professionals in outbreak response prior to COVID-19. So these wonderful physios on here were very heavily involved at the close of the year in supporting the governments of Samoa and Australian teams with a really significant measles outbreak. And this, as far as we're aware, is the first time that we've actually deployed internationally rehab teams, dedicated rehab teams in response to an epidemic on a national level. So this kind of great work is already going on, and I think there are lessons from that that we can learn for COVID-19 as well. Now, I'm originally actually an anthropologist by background prior to becoming a rehab person, and I want to draw on a fellow anthropologist and actually a North American who's also a medical doctor, Paul Farmer, who, when he was working on the Ebola response, developed a very simple way of synthesizing what's needed for outbreak response. And he categorized it under 4 S's, and it's very, very simple. It applies to both preparedness and response. I've absolutely shamelessly kind of ripped this off and applied a bit of a rehab lens to it. So all credit for this obviously needs to go back to Paul initially, but essentially staff is the first S. So we need to know that our staff first and foremost are safe, that they're trained for their roles, that they're prepared, and that they know clearly what their role is going to be. We need stuff, because without stuff, we're can't do anything. So basic stocks to be able to practice safely. This is for all for all preparedness for all hazards that I'm talking about now. Be able to manage surges in patients, and to be able to replace destroyed assisted devices. So stockpiles of equipment that would be required. We need space. We need to know where that is and how we're going to work within it and what requirements that space has. And we need systems. So as rehab professionals, that means we need to be integrated into disaster preparedness and disaster management planning, not just for the immediate phase, because that's often where the focus is, but for the whole continuum of care. And that's often where we fall down, is that a lot of disaster management focuses very much on what's going to happen immediately, and it ignores what's going to come in the future. And that's particularly where we play an important role. Those are the headlines from that. Now, the classic thing for all global health emergencies and the way in which they are defined at their most basic is that it's something that will overwhelm the health capacity of the country which is affected, and that's clearly what we are seeing with COVID-19. This is an example from Nepal. So how then can we draw on similarities between other kind of global emergencies and COVID-19, particularly for rehab professionals? So as we said, classically, that results in health services being overwhelmed. That's exactly the same in COVID as it is for any other global emergency. What we typically see then as a result of that is there's often a need to free up bed space by rapidly discharging patients who are safe to do so, and sometimes patients who require some additional support following discharge. Again, in many countries, we're starting to see that that is required to free up bed spaces for COVID patients. Normal services are then severely disrupted. So while there is a focus on the emergency, whether that's trauma care or, as we're seeing now, for COVID critical care, the impact is felt way beyond that. So if we think about basic things like stroke care or spinal care or orthoplastics, there is a kind of a ripple effect through all of the other services. And when we're planning our responses, we need to really heavily take that into consideration. A classic problem in most of the contexts in which we work is that staff will often lack the specialist skills to transition to their new roles. So classically, in an earthquake situation, we have huge influxes of major trauma, and we're looking at retasking staff who are not familiar with working, particularly in the acute kind of early rehab stages. And so it's a challenge to then safely transition people to those roles. And there are very difficult decisions to be taken about how we do that without creating risks for patients. Critically, what we then see is that patients in all disasters stay in hospital for longer than we would expect them, for shorter than we would expect them to. Particularly in disasters where there are ongoing waves of patients and there is a need to free up bed spaces, patients are moved through kind of critical care beds, acute medical services much faster than we would normally do so in a non-disaster setting. And that's clearly also going to be the case for COVID-19, and so that needs to be taken into consideration. What we also potentially see in disaster settings is surges in secondary cases. So, for example, earthquakes result in people being displaced or houses being damaged, and so you get lots of burns from people living in camp situations, cooking on gas stoves and things that they wouldn't normally be doing. In cyclones, you get people trying to put roofs back on houses and falling off ladders and putting nails through the hands or wading through murky water. In COVID, what we have is people being socially distanced, quarantined, isolated at home, and there are likely to be secondary consequences from that. Whether that means that children, for example, not being in school are more likely to be involved in risky behaviors, more likely to be exposed to burns, major trauma incidents and the like. I think we can realistically anticipate a similar knock-on effect with COVID. In disasters, one major challenge is often providing follow-up care once people leave acute care, whether that's because of insecurity or damage to roads and infrastructure or overwhelming numbers. And I think that we can say safely with COVID-19 that where numbers really start to go up, that we are going to see the same challenges that with additional problems like the fact that public transport infrastructure is not working, like the fact that quarantine measures are in place. And so we need to adapt what we're doing to be able to provide the follow-up care to people, both COVID and non-COVID patients who are being discharged from acute care facilities. And finally, in disasters, one thing that we really need to do is we need to ration equipment. So equipment is often prescribed very, very clearly on a risk management basis, not on a nice to have basis. And clearly we're going to see that with COVID. That goes for rehab equipment. We're already seeing that even with ventilator availability in a number of countries where very difficult ethical decisions are having to be taken around use of ventilators and prioritization of ventilators. That's no different from a humanitarian setting. And then to talk on a more macro level, so within the impact on the population and what we see from disasters, and again, it's not that dissimilar with COVID compared to what it would be for a conflict or an earthquake. So to emphasize that the most vulnerable will be the hardest hit. And we know that with COVID purely from the epidemiological data, because we know that about the groups which are more vulnerable to this disease. So we're talking about people with pre-existing conditions, so particularly people with disability and older people. But that is obviously magnified. It's further magnified then where we have marginalized populations. So that's applicable in humanitarian contexts, but it's also applicable in Canada, for example, where you have indigenous populations that Mike was alluding to. Populations that are otherwise potentially marginalized within the country, whether refugees, as we have in Europe. And then if you take that further and you look at extreme kind of camp situations, then obviously that is going to be magnified. So the potential for these kind of incredibly tragic disasters now in places like Cox's Bazar in Bangladesh, where we've got over 1 million Rohingya refugees, in Syria, in conflict-affected countries like Yemen, where the health systems are already on their knees, where people already have poor health literacy, poor access to basic, I mean, when we're talking about PPE and IPC, if you don't even have clean water to wash your hands, then it doesn't matter what advice you give, and it's going to be very, very difficult to apply those kind of standards in these camps. So if we think we're struggling for resources, those things are only going to be magnified in those settings. So we really need to be thinking not just on the kind of national insular levels, which a lot of countries are thinking at the moment, which is closing borders and how do we protect ourselves. We need to be thinking also from a global health perspective about the potential impact of this this disease in other contexts, and it's going to be much, much worse than it is for us. One thing we also see across all emergencies is there's always a strong need for coordination. That's both local, national, and international. And that's the reason why, as the UK EMT, we're providing support through Bronwyn and her colleague Gael into WHO to try and support that process. And lastly, we need to not just think about rehab, but also, I think, the protection of people with disabilities, who after all make up a large cohort of the population that we work with, and thinking about how we can be part of efforts to protect them from the disease and when and if they end up catching it. Just then to quickly draw on some lessons that we learned from the measles outbreak in Samoa. Now, I didn't actually deploy, but we were coordinating the team from the UK. What we saw was there was a huge need for highly specialized skills in respiratory and critical care. But with this being sort of smaller scale, it was very, very clear that the need was to get those people with the right skills, so the highly specialized skills, into the critical care environment. What that then meant is that we could redirect other non-specialists to support the kind of aftercare and other services. So that was the approach that was taken there. There was a need to consider the medium and long-term impact of the epidemic from the start. So measles, very, very different from COVID, but long-term impact of that did include chronic respiratory problems as well as neurodisability. And you have a window at the beginning of these things where everybody's writing policy documents and starting to think and map out resources and allocate funding. And if we're not talking about rehab from the beginning and the potential long-term implications of COVID-19 on rehabilitation services now, will miss the boat. So we need to be having those conversations from the very, very start. One thing that we did see in Samoa was the outbreak had a huge impact on other rehabilitation services. And we alluded to this at the beginning, but this is not just an outbreak that will impact upon critical care, it will impact across a whole host of rehab services, and how we adapt those is going to be critically important. There were also lockdown and quarantine. And as those rules changed or evolved, what that meant is there were surges of patients. So where lockdown was very, very severe, everybody stayed at home. When lockdown was then relaxed, we had huge surges of patients, both measles and non-measles, then coming into hospitals. And so I think we need to be aware of how changes in rules like that may change who's presenting to health facilities at different times. And I think lastly to say, and this is true of every disaster, is that disasters create opportunities. And that might sound kind of cold to be saying that now, but there is always an opportunity to actually build back better following or even beginning during a disaster, to make sure that we get stronger and better integrated rehab services. And I think that's true now. And if we start those conversations from this point in time, we'll be able to maximize that moving forwards. Just to quickly revisit the kind of the 4 S's from Paul Farmer. So staff. So on a very, very basic level, that means we need to think about training needs for COVID-19. We need to think about retasking and appropriate upskilling. We need to think about the diversion of services where appropriate. And in Nepal, we had a little mantra, which was we need the right people with the right training in the right place at the right time. And unfortunately, the main challenge is that we often end up with the wrong people, with the wrong training in the wrong place at the wrong time. So it's really about working and coordinating both between facilities, but on a national level, to make sure that we can move resources appropriately across to make sure that that happens. Speaking of staffing, you guys are probably familiar. There's a fantastic new publication on acute physiotherapy for COVID on a CPRC website. The link is there. I'm sure we can share this. Phil will, with the technology, we'll figure out how this can go around if it hasn't already within the resources that you guys have. In terms of stuff, it's the glaringly obvious. So it's essentially PPE. There is, of course, a need for the basic rehab equipment to support early home discharge, which I think is particularly important. So if we're moving people from a critical care environment home before they would normally be ready to go home, there is a need to put increased kit into place to make sure that they are safe when they do go home. And of course, the thing that everybody's talking about, and the kind of this is part of that at the moment, is sort of telemedicine and remote working, and making sure that we're properly equipped and prepared for that. That's the rehab side of stuff. Space. So what we're seeing is obviously rapid expansions of ICU capabilities. The introduction of sort of COVID bed. We had COVID pods in the UK in the early stages. We're beginning to see plans for step down expansion as well. Classically, what many countries are looking at doing are expanding kind of indoor centres into what are being called sort of SARI treatment centres, so severe acute respiratory infection treatment centres. WHO are now creating models for those, which are fabulous, which set out footprints and everything there that people can follow to produce those. But making sure that step down is part of that consideration. Occasionally field hospitals, but less commonly so. And of course, space, including the use of telemedicine and other services, and how we're delivering services in patients' own homes. And not forgetting that emergency needs are persisting, but the length of stay of patients, of all patients, is likely to be reduced. Systems, so discharge planning and follow-up. So classically in disasters, one of the biggest problems we face is we lose patients to follow-up. So we need clear patient tracking systems to make sure that that doesn't happen. Clear coordination and leadership, including where possible the development of standards. That's both national and international. Bronwyn can talk about some of the guidance from WHO. There's the beginnings of talk of agreed outcome measures that can be applied to this, so that we can actually get data on functional outcomes earlier in this response, so that we can start to consider that and the implications of that. Of course, the integration of rehab into a lot of the other systems that are already in place is absolutely critical where that hasn't already happened. We need systems to protect people with pre-existing health conditions that need ongoing rehab. That's really, really important. And again, telemedicine. That is it from me. I'm being really cheeky and just using this as an opportunity to also signpost a resource that we've recently published, which is not COVID related, which is early rehabbing conflict and disasters. And the link is up there on the screen, but you can also just Google that along. And I think that's me. So at that, I'm going to stop sharing. I'm not going to take questions now, but I'm going to mute myself and I'm going to hand over to Bronwyn, who is the clinical specialist in this, which I am absolutely not. It's been 10 years since I worked regularly in critical care. So over to Bronwyn.
I'll jump in here too. I just wanted to thank you, Pete, for putting that together. And really your experience in so many different areas is incredible. And I know even hearing about the work that you were doing in Samoa with the measles outbreak, I know there'll be a lot of questions, and it's incredible to see rehab capacity and experience in infectious disease. So now I'll introduce Bronwyn. So like Pete was saying, so Bronwyn is a critical care physiotherapist and a senior lecturer. And she's affiliated with Queen's University in Belfast, and she's also part of the UK EMT. And she's going to talk about what she's doing with the UK Emergency Medical Team, as well as with the WHO in terms of developing global rehabilitation guidelines for COVID-19. So Bronwyn, I'll pass it over to you.
Thanks very much, Phil, and thanks for all of you for the invitation to take part in this webinar with Pete. So yeah, I have no slides to go with this. This is a little bit of a more informal discussion and talk through about what my role will be, what my colleague Gael and I will be working on. And so yeah, just to give a bit of background, this collaboration with Pete and colleagues from Humanity Inclusion happened, I suppose, about a month or so ago, and then has rapidly evolved into actually the opportunity to take on this role a little bit more formally as a short-term secondment. And so my background, as Phil was saying, is in critical care for many years, and more recently working in clinical research over the last 10 years or so, particularly looking at physical rehab and how we look at patients' functional impairments during ICU, but also rehab following ICU admission through into the community, and how we follow up patients, both long-term outcomes and in particular around physical rehab. And so hopefully my goal is to bring some of that experience into working with Pete, Zoe, Gael, and many other colleagues supported by the UK EMT team and linking in with the WHO. And we have 3 particular outputs that we're aiming to bring together over the next month. And that will be to provide guidance for rehab professionals. So as Pete alluded to, there are some a fantastic example of some of the guidelines that have rapidly been produced for physiotherapists, in particular the physio management in the acute hospital setting, which I think the link has already been circulated. And so that just goes to show the speed with which clinicians have come together around the world to bring together some of this information to help guide practice. But what we want to try and do is also capture the range of other evidence that people have and are producing internationally, and think about how that evidence can be pulled together and applied across the range of settings that we'll come across. So not just in the higher resource, higher income countries, but how could some of these principles be translated into lesser resource or lower middle income countries, where, as Pete was saying, some of the facilities, the staff, the resources are not what we may be typically familiar with. And so I think that's one of the really important parts of this work, is to actually say, how can we best support colleagues who are in different settings, trying to adapt some of these guidances and some of these recommendations. So that's one key part. And we'll be doing more of a scoping exercise, looking at various sources of evidence, national, international, local guidelines, trying to put all of that together to get a coherent message, to kind of put that into the WHO language for a guidance for rehab professionals. And I think one of the things I've really learned, my learning curve in the last kind of week or so in terms of working in the, the humanitarian sector and how the WHO works. It has been near vertical. But just appreciating how, when we talk about rehab professionals, it may not just be physiotherapists in our kind of intuitive format is to think about our own profession, but actually, in settings that are less well resourced, it could be a variety of professionals delivering rehab. And so we need to think carefully about how we give some of this information and how we suggest these recommendations, because the assumption is that we will be working with in settings that are very similar to our own, but actually that's not always the case. So that's something that I've really taken home already, is about how important it is to think more broadly and laterally about the way in which this information can be disseminated. Our second document, our second output, will be another guidance document for health workers, particularly in those settings that are less well resourced, thinking about some of the information and the advice that we can give to those clinicians in particular. And I think that's where we're really going to be trying to target some of the settings that we wouldn't typically have access to. So for example, I could very easily draw together information that I know that comes from the UK, from Canada, from North America, from the US, from Australia, etc. But how do we try and capture information that's on the ground in some of these lower and middle income settings? And so using various networks, using contacts to try and access colleagues in those areas. And I know already that the physiotherapy document that we've spoken about already has been translated into something like nearly a dozen languages already, but many of those from some of those settings. So those will be contacts that we really want to try and make and access what information they might already have put together, but also think in particular about how we can serve those colleagues in those settings. And then finally, our third output is going to be looking at how can we produce some guidance to guide self-management for patients. As Pete was talking about, a number of these patients will be moving through the healthcare system much more rapidly than they would normally be. And that's across the board, that's regardless of setting. And so we need to think about how we manage that. So staff, colleagues on the wards are going to be seeing patients who are different to their normal. Patients going into the community are going to have to manage perhaps more independently than they would do normally. So the pressures on our community services will be far greater. So we need to think about, are there resources that we can give to patients to help a level of self-management, because we know that they're going to be exposed to a lesser degree of follow-up, more inconsistent and variable follow-up than we would ideally like, and that we know is possible across all of these settings. So are there advice and is there information that we can give them around some basic principles of self-management around their rehabilitation needs? So those are our three outputs that we're going to be particularly focusing on, and they should come out. We have a month to really focus in on those three outputs. Each of those will be progressing through that whole time, and Gael and myself will be particularly working there, and we're very well supported, and it's a fantastic team to be part of, with Humanity and Inclusion and the UK Emergency Medical Team, and very much colleagues from the WHO in the background, really giving us the guidance and the support to put those documents together. So it's a fantastic opportunity for me, a massive learning curve, but I hope that these outputs will be documents that have broader relevance across a number of settings, and really drawing on and signposting some of the fantastic work that's already been rapidly produced in different countries already, but trying to see how we can best serve a population at whole rather than a single nationality. So I'll stop there as well. It's a bit of a whistle-stop tour, but hopefully we'll be able to give you more updates on what these documents look like as we progress, and be able to circulate them around your networks once they're ready.
Just to add very quickly as well, there is a high-level guidance which is aimed at sort of ministries of health and service providers, which we're hoping will be ready in days rather than weeks. which will be of use to people, I think, to be able to help to influence decisions about making sure that rehab is considered within sort of planning and response to this at the moment. So that is in the pipeline at the moment. And just a huge thanks to Bronwyn as well, who's stepped away from her academic role very much at the last minute to come in and play a really critical role in this, and really great to have her on board as well. Thank you. I think that's the two of us. Back to you, Phil. Mike.
Yeah, thank you, and thank you, Bronwyn. And it is it's great to have someone with experience in such high experience in critical care, as well as in and to be able to step away from the academic side of it and really get going with this. So as a profession and as a physiotherapist, we definitely appreciate you being involved, and thank you for sharing that with us. I'm sure you have a lot of stuff going on, and I know you're taking time out of your day to share it with us. So thank you.
Pleasure.
So now what we'll do is we'll open up the floor to questions. And what we were doing before this session was that people could unmute themselves. But I think in this one, we're using a new platform with the CPA. So if you do have a question, I see that there's a hand up. But if you can ask the question in the Q&A at the bottom, and I'll read them out. And then we'll direct it to either Pete or Bronwyn. And just to let you know that we're going to be covering more broad level and not specifically kind of what is occurring within the UK, but kind of broad level within the role of physiotherapists, and we can even relate it to some of Pete's work or Bronwyn's work, and potentially some clinical questions as well. And we'll see how that goes. But let's see if anyone has any questions. So there is a question from Diana Hopkins-Rosseel, who's a Canadian physiotherapist that we know really well. And her question is, so is WCPT involved with the WHO and this UK initiative?
Well, you go first, Pete.
So our role as the UK EMT is to work on the initial drafts, and then WHO are leading on the peer review process. And within that, I'm certain, although I can't speak for WHO, that yes, they will be.
Nice, thank you. So any other questions? I see there's a question from Sean Cleaver about discussing equity, which I think he's asking when we can talk about that. And that is kind of Sean's specialty area that he's focusing on as an academic as well. So we definitely need to have that discussion. And I know both of you, and Pete mentioned it in terms of even how persons with disabilities are being affected by COVID-19 and including them in the discussion. So I don't know if that's really a question. I think Mike wants to answer here.
Yeah, let me just add a great question, Sean. And for those of you, I'm sorry you saw a little bombing of my child behind me a little while ago. Apologies. But so Sean, I actually had a conversation with one of your colleagues today, Matthew Hunt at McGill University, who I think really has created a career around global health and global health ethics, or certainly disaster ethics. And we had that very conversation, is we need to do more around equity. And what does that mean? Because as we start to move forward into the surge, at least here in North America, very difficult decisions are going to be made. And I would like to underscore what Bronwyn said, that in these environments, in these moments of austerity, decisions are not always, there is flexibility, there is fluidity to those decisions. And we need to be having that conversation well beforehand. So I think, Phil, we'll take Sean's point very seriously, and I think we'd love to invite, so Sean, no good deed does not go unpunished. So we're going to reach out to you and maybe Matthew Hunt, and maybe invite you to one of our next ones to really have that conversation, because I think much of your work, and Matthew Hunt's as well, have really leveraged some important discussions. So point well taken, and we'll put it in the planning stage.
May I throw one more comment into that as well, just as an observation? I think it's really interesting, you know, we're seeing discussions and like say the debates around acute medical care and equipment and resources, but actually, as I think as Pete really alluded to as well, that the equity around access to rehab, and the fact that we're already kind of thinking about that broadly in the UK, but I think the same thing will happen internationally as well, certainly in the higher income settings. The fact that actually some questions that we haven't really had to think of before around how we manage these patients and how we ensure that there's a fair distribution of access. And also importantly, we're there to remember the non-COVID patients. I think what often happens, not necessarily when there's a pandemic, because we don't have those very often, but actually even when there's a new device or a new technology that happens, you see all of the focus of attention goes on patients that receive that. And my concern is that we also don't forget the non-COVID patients in particular as well, and people will still be coming into ICU for non-COVID reasons as well during this time.
Absolutely. Thank you. So there are a few more questions that we have. If you do have a question, then you can type them in the Q&A section at the bottom. So one from Kathy, and her question is, are there any known long-term effects of COVID-19 other than effects of immobility for severely ill patients who survive?
Shall I take?
Yeah, if you want to, yeah. Go ahead.
Yeah, absolutely. No, I want Phil and Pete in on this one.
Yeah.
No, I think that the simple answer is no, we don't have that data yet from COVID-specific patients. And so we are drawing a huge amount on what we know already from critical care in general. And so I think, the nearest extrapolation you could go is to the literature from, H1N1 and other, infectious diseases in terms of outbreaks that we've had there, where we did do some follow-up specifically of those cohorts. But I think in general, what we'll be learning from is, we're fortunate in some ways in critical care as a community. In the last decade, we have made huge strides in our knowledge and understanding about the long-term consequences of critical illness, not just the physical immobility, but functional, cognitive, psychological impairments that patients experience, and also societal level, how many patients return to work, how many patients, economical situations change, how they integrate back into society with their roles and their different activities. So the whole range of problems that patients experience, we know much more about now than we ever did before, and I think that will serve us well in terms of addressing that for patients. So it's not COVID specific data, but I can't believe that it will be any different. We may, as we start to understand a bit more about the biology of the disease and its pathophysiology, there may be particular things that are relevant or unique to that population, but my huge guess would be that we will see much the same as as our general critical care population. I think one of the problems is the fact that we aren't able to manage those in the same way in terms of the speed with which patients are moving through the healthcare system. So that could be a problem whereby the severity of symptoms could easily be exacerbated because patients are discharged home much sooner than they would be perhaps without the regular package of care. And I think what I would also just flag in as one final comment, we also know now about the consequences on families and caregivers of patients and the psychological symptoms in particular that can fall upon them and the burden of care that comes to them. They are the unspoken carers that we don't capture, and then we don't necessarily care for in the same way. And I think that's also going to be huge for the long-term consequences of COVID patients, thinking about the burden for their families and caregivers, because they don't have the same access during the critical care time. We're already seeing visitation limitations in ICUs, so that causes huge stress, and so I think that will be also a problem that we'll need to be very aware of. So when we talk about rehab, I think it's important that we focus on patients, but also the families and caregivers as well.
Yeah, that was very well said, and thank you for bringing that up, Bronwyn. A couple points on that one. There is some data that is coming out from China. The researchers in China, given they're at a different phase of the trajectory, and Phil and I will summarize and kind of be posting those in this other website, that ptcovid19.org. Because finally, I think that there is a communication, and what we're going to try to do is to ensure that every single firewall is lifted during this time for journals, so that everyone can have access to it. I think that's going to be really important. The data I'm talking about is in JAMA. So we'll be, anyway, long story short is we'll be, let's all work together, but if you find out about information, please send it our way. We'll do the same. Maybe there is one central repository of editorialized parts that have been published. So I think you bring up some good points. We need to learn from the Chinese experience so that we can get better. Now, the other point that I might want to mention, although I do see there is another chat here, so I'll hold back and pass it over to Phil to maybe read off Ala's question.
Yep, sounds good. Thank you. Thanks for both of you for answering that in a really complete way. So there's a question from Ala here, and she says, are there any unified initiatives to prepare PTs in Canada or at provincial levels as of yet, given we are hitting the peak very soon? Also, how do you think we can prepare PTs for post-pandemic era, given the psychosocial impacts we are discussing? That is a great question. So I'll touch on I'll touch on the Canadian aspect of it, and then I'm going to turn it over to Pete. I'm going to shift it a bit at the end, and then we'll see kind of what they're doing and what kind of the perspective in the UK might be. So in Canada, basically what's been happening is, a lot of you know, and we've talked about quite a bit, is that the individual provinces, since Canada has a provincially governed healthcare system, the provinces are coordinating with the colleges to create a list of healthcare professionals that includes physiotherapists, and have been requesting that healthcare professionals like doctors and physiotherapists come out of retirement, and they're recruiting new grads to be deployed or to support in acute care facilities. So this is one of the things that we have been pushing for in Canada, is to build up at least the base skill level, so that everyone going into an acute care facility knows what they're dealing with, and building up skills in terms of infection control, personal protective equipment, treating COVID-19, as well as just working in an acute care facility, because a lot of people haven't been in an acute care facility or in a hospital for a while. So really what we're actually working with the APTA to develop a cohort of physiotherapists that are willing to deploy and go through a specific training program. So what we will do is we will offer the APTA, the training that we're developing for the APTA, to Canadians, or we're looking at doing that. So it won't be a mandatory thing, but we're looking at making that available. And if I thought Mike was going to jump in there for a second, but I'm going to switch it over to, no, shaking his head. Okay, so I'm going to actually turn this into a question for Pete as well, because I actually had that question too. So because of that, that's one of the things that we're pushing for in Canada, is really, how do you scale up and really train physiotherapists to be ready for this type of work, especially, if a lot of the clinics across the country here have closed. So we have a cohort of physiotherapists that are willing to either volunteer or work within acute care facilities and hospitals. So could you maybe talk a little bit about either what, through some of your work with the UK EMT, what could potentially be done in terms of COVID-19? And even if you can't touch on COVID-19 specifically, maybe talk a little bit about the work that's been done with the UK emergency medical team, and the roster that you have, and the training that's involved.
Yeah, absolutely. So I can't, again, talk about the situation in the UK with COVID-19 because I've just been so focused on the kind of international side. I haven't really been following what's going on here so much. In terms of when we prepare people for deployment with the UK emergency medical team, there's a kind of a series of steps that they go through. There's a basic selection process, which looks at whether they have the right kind of personalities and aptitudes to work in such a high pressure environment, really focused on whether they're sort of team players, whether they're able to adapt what they do, which is absolutely critical in these kind of contexts. And then when it comes to the clinical side of stuff, we have role-based competencies, which people self-assess against, and then we train against. We then teach sort of adaptive clinical training, which is how to adapt your normal practice for working in a resource or high pressure, resource constrained or a high pressure environment. And finally, we tend to do actual kind of field-based training in simulation with people. Now, I'm not saying that that would be a model now for preparing people for COVID-19, but I think that the idea of sort of defining competencies for specific roles and then training people against those for COVID-19, or at least assessing people against those and then training potentially to fill some small gaps is probably the way to go for this. The model, though, needs to be different in every single country depending on the kind of background training and things that people have. So in some countries, physios are not involved in critical care at all. So to think about starting from sort of a very low level to upskill people to work in critical care, the risks in that are very, very high. And so there are difficult decisions that need to be taken. In other settings where people are more routinely doing on-call or rotational work and are exposed to critical care a lot, it's much easier just to then upskill people and move them across. So those are kind of country and in some cases sort of region or hospital-specific decisions that need to be taken.
Okay, incredible. Thank you. Even after saying that no one should ask a question about what's happening in the UK, I managed to ask a question about what's happening in the UK. So there you go. Made the one mistake that I said not to make. So thank you for sharing that. And one of the reasons why I wanted you to talk about that too is because it is such a unique model throughout the world, and it's something that we're actually kind of trying to get something going here in Canada that would at least be developing a roster of physiotherapists and getting them to a base level so that at least we would know what people's competencies are, and then we would try to build in structures where we could identify, say, things that might be coming, like in this case with COVID-19, knowing that there was an outbreak in China and recognizing the signs of that, and that if we had that roster or that list of physiotherapists or healthcare professionals, then it would have been a little bit easier or streamlined in terms of building up competencies. Whereas now we're at a point where we're in a response. We're also trying to build a list and we're trying to train people. So it adds a lot to the complexity. Yeah. So thank you. And it's a really good model.
Phil, can I draw your attention and our attendees on the webinar? There are two publications, and I'm happy to send them through if you haven't already come across them, but from Australia and one from the UK around the minimum competencies for clinicians working in critical care or in intensive care. And they were both developed with the intention for informing undergraduate curriculum, and also for clinicians who may be on the on-call rota but perhaps don't routinely work in ICU. And that sometimes does happen across a number of hospitals where, for whatever reason, their staffing numbers aren't sufficient to only have respiratory physios on the ICU and on-call rotas at weekends and so forth. And so whilst we probably don't necessarily have the time to get to, whilst we're trying to train clinicians, they could be useful models for at least giving some basics and some kind of framework to what competencies you might be expecting.
Okay, great, thank you. Yeah, thanks, and we'll share all of the resources afterwards too. Now, were there any other questions from the floor, or from your bedrooms or couches?
Jenny had one. I added a point here, but let me just read it. In terms of mobilizing the sort of disaster relief that was discussed, where does the leadership lie? Is it national branches, international organization, individual health profession bodies, working to lobby government? Sort of just wondering sort of some of the mechanics. And I'll just say one point, and then maybe we'll give it to Pete to take us home on this event. But you know, I think there's opportunity personally, and I think Phil and I are on the same page. This is not an opportunity, but it is an awakening for us to start thinking about, do we have emergency plans? The worst time to develop an emergency plan is while the emergency is happening. And we've known that. And the hard part, and one of the challenges among, and I won't speak for everyone, but you know, this is sort of what people like Peter have been doing for a decade plus. And, you know, I think we need to leverage on some of the skills that we have in our own physical therapy community around the world. We will build back better, to use one of the points that Peter talked about. And building back better really means having a strong plan, everyone knowing what the plan is, and then even more so, including those students that we just talked about in those competency frameworks. I'm not sure there'll be a day like last year ever again. We're moving, we are now getting sort of kicked into the future. Whether we're talking about telerehabilitation or preparedness and disasters and what the roles are. But shame on us if we don't learn from this. And so Pete, let's pass it over to you for, and I'll just say, I'm not trying to be funny or anything, but man, if I had your accent, I think people would listen to me more.
It's not true, mate. It doesn't work. Sorry. All right. So the cold answer, I guess, is that on a national level, in terms of kind of coordinating and drawing forward support and everything like that, the responsibility lies with the national authorities. So the Ministry of Health, and the Ministry of Health will normally have some kind of a health emergencies platform, which will lead on that. And they're called different things in different places. In the Americas, they might be called a CECOM, which is the kind of Spanish equivalent. In English-speaking countries, they're HEOCs, Health Emergency Operations Centers. And that's a standard model that applies, that takes on different forms and is called different things, but essentially the model is the same the world over. So if an international organization wants to respond, whether it's an earthquake or a disease outbreak, they would normally only do so and should only do so in response to a request from that mechanism. And if that mechanism isn't working, then potentially from WHO. That's the kind of the cold answer on the national level, how these things should work. The reality then is, if we want to then influence this as physios in the countries where we are, there are 4 different levels. So you've got your national health emergency plans. We're often not in those, or if we are, it's often lip service. And so we need to make sure that we're included properly in those. Then you've got your regional one, same thing applies. Then you've got the hospital one, often the same thing applies. And if you look at some of the research that's come out of past disasters, whether in high income settings or low income settings, one of the strongest things that always comes through is that rehab professionals and physios, in particular on a hospital level, had huge amounts to offer, but they did not have a defined role in the first few days. And so we need to address that by getting ourselves into those plans on all of those levels. And that's going to require advocacy, and that requires leadership from professional bodies, particularly physiotherapy associations, to help to make sure that that happens. We also still have to persuade people of our value, I think, sadly. And I think that there is such a focus often in these situations on life-saving care that people are not thinking about what happens next. And so we need to constantly drive home this message that life-saving care is clearly the most important thing and of vital importance. But if we don't think about what happens to people after we've saved their lives, then we're frankly being negligent in terms of our responsibilities as responders to this. The last thing to say is we've covered national, regional, and hospital. It's also individual, which is that everybody needs their own plans in place. And I think people laugh at me in the past when I talk about this in kind of high income settings in Western Europe, in North America, about having a personal preparedness plan. If people were involved in kind of rushing out to try and buy toilet paper and dry goods and things in the UK, then I think they might now be thinking about that slightly differently. But it goes on all levels, and we need to think how we're protecting ourselves and our families first and foremost, and then we can address the other bits. I'll finish on that. Thank you.
Yes, yeah, thank you so much. And thank you to both of you for being here and really sharing your experiences. You both have such incredible experiences all around the world and within the UK. So we really appreciate you being here. And I hope you stay well and happy through all this. And I'm sure that we'll be in touch and sharing resources throughout. And thank you all for being here and coming to listen. Thanks, everyone. Good night.
Thanks, everybody. Good night.